Good evening, everyone. I'm Jane Ransom, the Executive Director of the American Brain Foundation. It's really nice to see so many people here tonight. Our host for the evening is Kelly Lubanko. She's a Houstonian whose passions are the arts, child causes, and wildlife. And she has, and I'm quoting her, 2 brilliant daughters and 3 perfectly brilliant grandchildren. And one of the perfectly brilliant grandchildren gave her a gigantic cold and she can't be here tonight. And so her daughter, Elise Lubanko McKinney, was kind enough to step in and share Kelly's remarks. Elise?
Hello, and thank you for attending this evening. I'm Elise Lubanko McKinney, subbing tonight for my mom, Kelly Lubanko, who is home with a bad cold. She sends her apologies. Alzheimer's is an issue that is near and dear to my family's heart, as we have lost several relatives to the disease. Most recently, my mother's father. The American Brain Foundation promotes and invests research across the whole spectrum of brain disease. Funding research across a broad spectrum of the brain and nervous system is our best hope for finding better treatments, prevention, and cures for the brain diseases, affecting 1 in 6 people. That's over 1 billion people across the globe whose lives are impacted by brain diseases like multiple sclerosis, Alzheimer's disease, Lewy body dementia, stroke, migraine, epilepsy, and more. ABF's goal is to bring that number to 0. Believing in a whole brain approach gives ABF an edge in understanding and combating brain disease. They understand that when they cure one brain disease, they will cure many. On that note, we invite you to sit back, relax, and learn with us this evening. Thank you again for being here.
All right, now we're going to turn it over to Dr. David Dodick, our board chair.
Thank you, Jane, and thank you, Elise. Good evening, everyone, and thanks so much for being here tonight with us. This is the American Brain Foundation's April installment of our donor salons. And tonight we're featuring a very special guest to walk us through new frontiers in dementia research. As Jane said, I'm David Dodick. I have the privilege of chairing the board of directors of the American Brain Foundation. And these evenings are very important to us as they enable us to bring donors and researchers together. And so it's great to show our appreciation for to those of you who have donated to the American Brain Foundation. It allows us to highlight the very top echelon of researchers to update you all on research advances across the spectrum of brain diseases. And your support allows us to fund the top research proposals submitted by incredible young and established scientists from around the country that will move us closer to treatment advances and cures for brain diseases. The only regret is that we're only able to fund about 10%, believe it or not, of the scientists who submit very high quality research proposals to the American Brain Foundation. So we leave a lot of remarkable research and talent on the table, and that's why we're absolutely committed to raising the level of support and funding to support the biggest and boldest ideas that these bright young people across the country have. Tonight, we're fortunate to be joined by Dr. John Morris, who is the Harvey and Doris May Hacker Friedman Distinguished Professor of Neurology. He's a professor of pathology and immunology, professor of physical therapy, and so much more. He's also a named professor. He's the Charles F. and Joanne Knight Alzheimer's Disease Research Chair at Washington University School of Medicine. His research interests are primarily in healthy aging and in Alzheimer's dementia, in particular identifying antecedent or pre-symptomatic disease biomarkers for Alzheimer's disease in non-demented elderly individuals to evaluate the risk for Alzheimer's dementia, and then pioneering trials of investigational drugs for the treatment of Alzheimer's disease. He's co-authored 4 books and more than 570 published articles. And for those of you who are in the know, that's a lot of papers. He's currently a member of the board of directors of the American Academy of Neurology, and he serves on numerous scientific and community advisory boards. He's received so many honors and awards that it would take me another 5 minutes to actually go through them all. But just to name a few, the Lifetime Achievement Award from the Alzheimer's Association, the MetLife Award for Medical Research in Alzheimer's Disease, the illustrious Potamkin Prize for Research in PICS, Alzheimer's disease, and other related dementias, and many more. He's also the Physician Scientist Lifetime. He won the Physician Scientist Lifetime Achievement Award at the Barnes Jewish Hospital Foundation in St. Louis. I guess to sum it all up, he's ranked in the top 1% of investigators in the field of neuroscience and behavior by Essential Science Indicators database. For us, we're very fortunate that he has served on the American Brain Foundation's Research Advisory Committee for the past 6 years, and he's led our biggest ever initiative, which is in Lewy body disease, to identify a biomarker for that disease. So that is the biggest initiative financially that we've ever led, and we're fortunate that Dr. Morris has led that for us. So John, take it away, please.
Thanks so much, David, and welcome everyone. I appreciate everyone joining this evening, and I'll give a brief overview of the current state of research in Alzheimer's disease, and then leave plenty of time for any questions that people may have. And I don't think I need to tell this audience about the epidemic of individuals with Alzheimer's disease and having dementia as the hallmark characteristic of this illness. Many of you I know have had personal experience with the illness. We heard from Elise very compellingly about her family's dealing with Alzheimer's disease dementia, and all of those who have that experience know that it is a miserable disease, and one that no one survives. No one who develops Alzheimer's disease has ever been cured of the illness, and death is inevitable. So with that terrible introduction, I want to try to indicate what I think should lead us all to have some cautious optimism that for the first time since I joined the research in Alzheimer's disease in 1983, almost 40 years ago, I think there could be the opportunity to develop truly effective therapies for the illness. So I'd like to give you some insights into the current status of drugs being evaluated for treatment of Alzheimer's disease, and also mention one other, I think, very important advance in the ability to diagnose the illness. We all know that the year 2020 is the year of the COVID-19 pandemic. It will always be thought of in terms of the pandemic. But we also, in Alzheimer's disease, might look back on the year 2020 for two very important advances. First, in July of 2020, a drug company, Biogen, submitted data from a drug that it is investigating for the treatment of Alzheimer's disease to the Food and Drug Administration to ask the FDA, Food and Drug Administration, to approve it for the treatment of Alzheimer's disease. This has been a long time coming. We have had some drugs approved by the FDA for the treatment of the symptoms of Alzheimer's disease, but nothing to actually treat the disease process itself. And that was the significance of this submission in July of last year by Biogen of data on its drug that the company thinks deserves to be licensed for the treatment of Alzheimer's disease process itself. Now, the drug has a long and hard to pronounce name. It's aducanumab. I'll spell it ADUCANUMAB, and it is an antibody that is targeting a brain protein that we think, when misformed or misprocessed, starts the Alzheimer disease process. This protein, we all have it in normal circumstances. It doesn't cause any problems. But if something goes wrong such that it begins to build up abnormally in the brain tissue, it causes the onset of the Alzheimer disease process. This abnormal protein is called amyloid beta. And this drug, aducanumab, is, as I mentioned, designed to target amyloid beta, get into the brain tissue, find the deposits of amyloid beta in the brain, and remove it. Now, this sounds good, but other drugs have been developed to do the same thing, and yet, even though they appear to remove the amyloid from the brain, amyloid causes one of the two hallmark brain lesions that we use to diagnose Alzheimer's disease when we examine the brain tissue under the microscope, the amyloid plaque. And as I mentioned, it's caused by this abnormal conglomeration of amyloid beta protein. The other hallmark is the neurofibrillary tangle, and it's caused by an abnormal metabolism of another brain protein called tau. Well, other drugs have attacked the amyloid plaque and seem to have an effect in removing the amyloid plaque from the brain, but it didn't seem to help the patients. So even though the amyloid was being exited out of the brain tissue, the individuals continued to progress with their dementia. They did not get better. They didn't even plateau. They continued to worsen. But what Biogen thinks its drug, its anti-amyloid drug, will do is not only remove amyloid from the brain, and I think we're all pretty convinced that the drug does do that, but those individuals who had the amyloid plaque removed by this drug seem not to deteriorate to the same degree as people in the same study who were given a placebo, a sugar pill, not the active drug. So Biogen says this shows not only does their drug aducanumab attack the basic protein that we think it initiates the Alzheimer's disease process, it benefits patients. The Food and Drug Administration has been deliberating whether to approve the drug for the treatment of Alzheimer's. And it originally was going to give its decision in March of this year, but it has delayed its decision until early June 2021. So about 6 weeks from now, we should hear from the FDA whether the drug will be approved or not. The reason for the deliberation by the Food and Drug Administration is there's some controversy over the data presented by the drug company for review by the Food and Drug Administration. As it turns out, the data came from two identical studies of the drug aducanumab, and one study seemed to show this benefit that I mentioned, removal of amyloid plaque from the brain, slowing of dementia progression, benefiting patients. But the other study, although it was designed identically, did not show that it benefited patients. So it's controversial. Should the drug be approved based upon one study, or is the other study closer to the reality? And many investigators think that perhaps the drug submission to the FDA was premature. We need more studies and more people and more convincing evidence that it truly benefits patients. But we will see what the regulators at the Food and Drug Administration determine. And if it is approved, it's a game changer. We now will have many people with Alzheimer's disease dementia and their families wanting to have access to the drug. And this is unfortunately going to require tremendous change in how Alzheimer's disease dementia is diagnosed and treat it. We do not have the capacity to diagnose everybody with Alzheimer disease dementia. The people who are most experienced with this are really quite few in the country. And it turns out that although there often are figures given to say that 5 or 6 million older adults in the United States have Alzheimer's disease, that's almost certainly an underestimate, because another 5 or 6 million individuals who have Alzheimer's disease dementia are undiagnosed. Their physicians do not recognize it or diagnose it. So all these people now are going to, well, many of these people will want access to the drug, but first they're going to have a firm diagnosis of Alzheimer's disease dementia, and who will be available to make that diagnosis. Second, they'll want to have confirmation that in fact they have amyloid plaques in the brain. We can do that. We have a variety of techniques to identify amyloid plaques in the brain. One of them is a sophisticated imaging study called a PET scan, and it can detect amyloid in the brain. But PET scanners and the expertise to do this are really few and far between, often at large academic medical centers, and many people not living in the vicinity of an academic medical center won't have access to the PET scanner, so they won't have the confirmation that they have amyloid plaques in the brain. Now, this is very important because you don't want to give a drug to individuals if the target of the drug, in this case amyloid plaque, isn't there, because you're just exposing individuals to potential side effects of the drugs without giving them any chance to have any benefit. Then finally, if someone gets a firm diagnosis, has amyloid in the brain confirmed by an amyloid PET scan, then how will they get the drug? It's an infusion, intravenous infusion. It takes place once every month, and presumably will take place for the rest of that individual's life. At least if it does benefit them, they'll have to continue to get the infusion. We don't have the capacity now for infusion centers to do all of this, and who will pay for it all? And all of these are big questions. We frankly will be happy to tackle these big questions. We would all really want a drug that is effective in treating Alzheimer's disease, but it will require a great deal of preparation to be able to treat everyone who thinks they would like to have the drug. Now, there are two other caveats. One is, I mentioned you don't want to give a drug to somebody who doesn't have the target that the drug is designed to attack. And all drugs, including aducanumab, have potential side effects. One of the side effects that is most frequent in aducanumab is it can cause brain swelling in about a third of the people who get it. Now, we think the reason for this is, I mentioned that a telltale sign of Alzheimer's disease is the presence of amyloid plaque in the brain. Well, amyloid also deposits in the walls of the blood vessels of the brain. And the drug doesn't differentiate between plaques in the brain tissue or amyloid beta deposited in the blood vessel wall. So it will try to remove not only the plaques, but the amyloid in the blood vessel wall, thereby potentially weakening that vessel wall, leading to the leakage of the contents of the vessel. Could be just fluid, but could also be blood, could be a hemorrhage. And the way we have to evaluate this and track it is by getting brain MRI scans periodically every few weeks or months to make sure that this complication isn't developing. So it's not a benign drug. It does require surveillance with brain MRI to avoid this potential complication. The other complicating issue is this. All of the studies that the Biogen pharma company did with this drug, aducanumab, were in people with pretty mild Alzheimer's disease dementia. And I think the vast majority of people who will want access to this drug will be more progressed in their dementia severity than the people who actually contributed the data that the FDA are reviewing. If the FDA approves a drug, they may limit it only to the people who they know it, if they think it benefited, people with very mild disease. So how are we going to tell families with loved ones who have more progressed disease that they can't have access to the drug because we don't know if it works once the disease is more progressed? So these are all complications, potential complications. Once again, I think as a field, as a American Brain Foundation, as the Alzheimer's Association, these are big problems. But boy, if we had a drug that works, we're ready to try to address them and to try to work through all of these issues. Now, there are other drugs that are in the pipeline. So if and that have similar promise as aducanumab. So if for some reason the Food and Drug Administration tells Biogen that perhaps more data are needed to verify that the drug truly does benefit patients, well, we have other candidate drugs that have also shown some promise, and their results will be forthcoming too. So I think we are on the, as I said, on the cusp of finding if not in June of 2021, within the next few years, drugs that really do remove the brain pathology of the amyloid plaque and provide benefit to patients. So the first such example of that, as I said, happened in July of 2020 when the drug aducanumab data from the trials of that drug were submitted to the FDA. So it could be a landmark if that drug is approved or one of its cousin drugs gets approved in years to come. The second big event in 2020 is that we have a blood test now that will tell people with pretty high certainty whether or not they have Alzheimer's disease. This blood test also measures this protein I've been mentioning, amyloid beta, and abnormal levels of amyloid beta in someone's blood will, with very 92% certainty, indicate whether the person has amyloid beta in the brain, amyloid plaques. So this is also a major step forward. I've been talking about amyloid PET scans, which are not very accessible to the vast majority of patients because they're so limited. They're also very costly, cost something like $6,000, I believe. It's not reimbursed by Medicare, but a blood test, much more accessible, and I think much more acceptable to people. Right now, it has not yet been approved by the FDA. It was just released for clinical use, I think, in November of 2020. But it is something that can be ordered, and a company will be able to provide the results within a few weeks of sampling the blood. And it's not yet covered. It's not covered also by it also is not covered by Medicare or any insurance carrier. I think it costs on the order of something like $1,250. So it's not as much as a PET scan, but it does cost the person out of pocket to get the test. But I think with time, as more and more people find its utility in the clinical practice and the diagnosis of Alzheimer's disease, that will hopefully find that it does get reimbursed by third-party payers, and so it won't require out-of-pocket tests. So this is another potential game changer to have a blood test readily available. It's like getting your blood glucose evaluated if you have diabetes, and if you're concerned that you might have Alzheimer's disease dementia. Now a blood test is available and will, I think, really advance the ability to make accurate diagnoses as well. So those are, I think, some of the research advances I wanted to indicate to this group. There are many other things to discuss regarding Alzheimer's disease dementia, but as I say, I think the field as a whole, with new means for diagnosis and many more people via a blood test and possibility of a disease-modifying drug therapy, we feel that the opportunities for truly meaningful change in Alzheimer's disease lay before us. And it's been a long time coming, but I'm very hopeful that 2020 set the stage for benefits for patients and their families. So with that, why don't I stop and be happy to address any questions that people may have.
John, that was fantastic. Thank you so much. And it's a remarkable advance. And as you say, hopefully a game changer for the field and most importantly for patients. A number of questions have come in through the chat. So I'll take one of these one at a time. I'll start from the top. So this question is, what percentage of dementia is Alzheimer's disease? Or what proportion of patients with dementia represents Alzheimer's disease? And how many other kinds of dementia are there?
Well, I'll take the second of that first. Once I counted all the different brain conditions that could cause dementia, I got up to over 100. So there are many disorders besides Alzheimer's disease that cause dementia. However, Alzheimer's disease, I think by far, is the leading cause of dementia because it is age associated. The longer we live, the more at risk we are of developing Alzheimer's disease dementia. And the reason it is a coming epidemic is, of course, our population and populations in many developed countries throughout the world and emerging countries throughout the world keep getting older. So we have more and more people reaching the age at which Alzheimer's disease dementia develops. And I'd say about 93% or so of people, of everyone who has Alzheimer's disease dementia is age 70 and older. The older we get, the more likely we are, more at risk we are for developing the illness. Now, I said age associated, Alzheimer's disease, strongly age associated. I don't think it's necessarily age related. That is, if we all live to 85 or 90 or 95, will we all get Alzheimer's disease dementia? I don't think so, because we have people who live a long life and retain all their faculties. So not everyone who is going to live a long life will necessarily have Alzheimer's disease dementia. So I think it's strongly age associated. That's why we see so many more cases all the time as people get older and older, but it's not the same thing as aging. You can live a long life and stay cognitively, mentally intact. I think the oldest example of this was a woman in the Netherlands who died she was 116 when she died. She not only was cognitively normal, she'd been tested by a university in the Netherlands, and she was intact with her memory, and she donated her brain for autopsy, and they found no evidence of Alzheimer's disease. Now, obviously, she's unique. No, I mean, who lives to 116? She's pretty unusual, but she didn't have Alzheimer's disease. So it's possible to live long without Alzheimer's. One other important point, there are other forms of dementia besides Alzheimer's disease. For example, strokes, if they affect the memory and thinking area of the brain, can cause vascular dementia. We've heard about Lewy body dementia. There's frontotemporal dementia. There are, as I say, many other causes of Alzheimer's disease. And it's important to recognize that there's nothing about having Alzheimer's disease that protects you against these other conditions. So it's very common, for example, with people who have Alzheimer's disease dementia if their brain is studied at autopsy, they'll have other pathologies such as strokes in addition to Alzheimer's disease. So few people die with pure Alzheimer's disease dementia. More often, it's probably multiple factors in addition to Alzheimer's, but by far, I think the most common and the most important is Alzheimer's disease. Now, I confess to some memory problems myself. So I think I answered part of the question, but I've already forgotten the first part of the question.
No. You answered it all. You answered it all. And in fact, your point about there being over 100 different diseases associated with dementia underscores your earlier point about the importance of a diagnostic blood test. I mean, that's huge, given the fact that there's so many causes for dementia.
Yes, correct. And many illnesses can mimic Alzheimer's disease. So it is important to get an accurate diagnosis, and particularly if there were to be a truly effective treatment for Alzheimer's disease.
Yep. The next question here is a good one. Would it be appropriate to use the new drug, if approved, as a preventive before any sign of Alzheimer's disease is detected?
I really like that question. And I'm going to I'm going to give a short answer, yes. I'm going to give a longer answer. And it's a little bit complicated, but we know that the Alzheimer disease process begins in the brain 20 or 25 years before it causes enough brain damage that the brain function begins to fail, and hence the symptoms occur. Now, if Alzheimer's disease, the areas of the brain that are most vulnerable to this disease process are those areas involved in memory and thinking. So when those brain areas are damaged and the brain function fails, we see problems with memory and thinking. But at that stage where the dementia, the memory and thinking problems occur, already it's been 20 or 25 years that silently the amyloid plaques, the deposits, the tau abnormalities have been building. And if we think about it, when the brain gets damaged so that dementia occurs, that might, in some ways, I think we always are going to need to focus on treating people who have Alzheimer's dementia. But if you think about it, the reason they have dementia is the brain has been damaged. That's why you have the symptoms. And the brain damage is nerve cells are lost. They're dead, and we have no way to restore them. Remember, I said that the Biogen company targeted people with very early symptoms of Alzheimer's, very mild Alzheimer's dementia, hoping to treat at a point when the brain damage wasn't very severe. But I think even better, as the question indicates, would be to start treatment before there's brain damage, before there's dementia. And we can do that. We can tell about this buildup, this silent buildup of the brain pathology by using techniques such as that amyloid PET scan that I described earlier. We can examine the concentrations of amyloid, beta, and tau proteins in the spinal fluid. The spinal fluid is manufactured in the brain and is a very important aspect of brain health. It protects the brain and protects the extension of the brain, the spinal cord, but it also carries concentrations of brain proteins. And if we remove a portion of that fluid by a spinal tap, we can analyze the concentrations of amyloid and tau and know whether the disease process has begun. And now, potentially, we can tell the same with a blood test. So I think we can identify people in whom the Alzheimer process has begun, but they're still doing fine in terms of memory and thinking. They are asymptomatic. But yes, it's appropriate to target these individuals with drugs such as aducanumab in an effort not to slow down dementia, but to slow the onset of dementia or maybe even prevent it. Now, I will just take a moment and compliment my colleague here at Washington University, a man named Randall Bateman, who initiated the first such prevention study in people who had no memory and thinking problem, but were at extremely high risk of developing Alzheimer's dementia. And Randy started that study in 2012. It was controversial. How can you give drugs to people to treat dementia when they don't have dementia? How is that possible? But he and his team did a remarkable job, and other such prevention studies have followed. And I think that is a very important area for Alzheimer research. I'm not a very smart person, but I will take some moment to just give an analogy from our colleagues in cardiovascular medicine. They often will treat people who have coronary artery disease, hardening of the arteries, and all that fatty buildup within the blood vessel wall that prevents blood flow and causes heart attacks. Well, they will tell you that they would much prefer to treat coronary artery disease before the heart attack. They would want to control your blood pressure, want to control your lipid levels, want to keep inflammation down, want to keep people healthy and prevent heart attacks. That's a much more effective strategy than trying to treat somebody with a damaged heart because they lost blood flow and the heart muscle was damaged. And it's the same with the brain. Let's try to treat Alzheimer's disease, the precursor before the brain damage occurs, and try to delay the onset of dementia or even prevent it entirely. I'm sorry, I'm got a little excited there. I apologize.
No, well, to your last point, John, the next two questions are, other than drugs, or I guess in addition to drugs, what else, while we're waiting for aducanumab, can people do if there's a family history, or if they know they're in the prodromal stage of the disease? What can they do to prevent the onset or delay the onset of the disease? Is there anything they can do?
I think there is. It also is complicated, but I and my colleagues advise all of our patients, including those who come to us because they are not now demented, but they are at risk of becoming demented, perhaps because they had an affected parent. And what can we do to reduce our risk? So here's what we advocate: a heart-healthy diet. Turns out what's bad for the heart is bad for the brain. So heart-healthy diet. And staying engaged. Now that means mentally engaged, physically engaged, and socially engaged. So these are things we can all do. The complication is we don't know for certain whether or how these lifestyle practices might reduce risk for Alzheimer's disease. And I give this analogy, and not a very good one, But if you took a group of 75-year-old individuals, half who had mild Alzheimer's dementia and half who were perfectly intact in memory and thinking, and you looked at the lifestyle practices of these two groups, many more people in the cognitively intact group will have had a history of playing bridge or doing Sudoku or physical activity and things of that sort compared to the Alzheimer group. So you would say, geez, look, they are doing these healthy lifestyle practices and they don't have Alzheimer's disease. Here's the consideration. It's possible that playing Sudoku had nothing to do with the fact that they seemed to have no Alzheimer's disease dementia. Maybe they were born with a bigger, better brain or had some protective factors, and the fact that they had a bigger brain led them to do Sudoku. But what protected them wasn't the Sudoku, is the fact they had some genetic or environmental advantages that the brain stays healthy. So the reason I mention this is there are individuals who have been remarkably good at staying cognitively intact and physically active and socially engaged and eating well, and they still develop Alzheimer's disease dementia. There are Nobel Prize winners who have Alzheimer's disease dementia. So staying cognitively intact and playing bridge is not a guarantee that it will reduce risk. Now, maybe we'll find with more research studies that it is helpful, but at this point, I think we do it because it won't hurt. It may help, but we cannot guarantee that these lifestyle factors can reduce risk. We hope it does, but we can't guarantee that. Does that make sense?
Absolutely. Absolutely. This is kind of a crystal ball question, John. Realistically, how far out in years until there will be a drug treatment for Alzheimer's disease that's widely available?
So I mentioned I started out in the Alzheimer disease research in 1983. The first drug was approved for the treatment of Alzheimer's disease in 1993. It was a drug called Tacrin or Cognex, and it was a drug not treating the brain illness, but treating the symptoms. It wasn't a very good drug, but it set the stage for cousins to be developed. One of them that was approved in 1996 is donepezil. Some of you may know it by its trade name, Aricept. So those two drugs were very similar. So when Cognex was first approved, first drug ever approved by the FDA to treat the symptoms of Alzheimer's disease in 1993, I was young and naive, and people asked, well, when will we have a cure for Alzheimer's? And I very confidently and blithely said, well, I think in 5 years. Well, we know that that was premature, and it's a very complicated illness. I mentioned two disease processes. We think amyloid beta starts it, and then comes the tau. But there are many more disease factors that once the disease process starts, comes to play. There's inflammation in the brain. There's something called oxidative stress. There are all kinds of other proteinopathies. It's complicated. So it's not going to be an easy drug to treat. I think aducanumab is, if it works, or those other drugs that I say are coming close behind it in the drug pipeline, if they work, great, I'll take them. But I'm a little concerned that they're only treating one of those brain processes. That's the amyloid process. And they're not taking care of the abnormal tau, or they're not addressing the inflammation, or they're not addressing the free radicals that come with oxidative stress. I ultimately think once the disease causes dementia, that we might have to think of combination therapies. This is, again, not unique to Alzheimer's disease. That's what happens in cancer all the time. Chemotherapies of different drugs attacking different parts of the cancer-producing illness. And I think ultimately we'll have to get there. So I told you I think that we'll have a drug, one or more drug, amyloid-based drug, hopefully within the next several years. I won't say 5 years, but next several years. But I think the bigger question for people who have Alzheimer's dementia is going to be, what are the combinations of drugs that will be best to try to halt the dementia process once it is there? And no one has started that. That hasn't begun yet. So I think we're a long way to treating Alzheimer's disease dementia truly effectively. I hope I'm wrong. I would love to be wrong. I have more optimism, and again, a cautious optimism, that the prevention studies may show benefit before we have a truly effective combination therapy approach to treating Alzheimer's dementia.
Thanks, John. You piqued everyone's interest with the blood test, and so I'm going to combine a number of questions here, which is the name of it, the manufacturer, and at what stage of the disease can it be detected? In the prodromal, mild, moderate, severe?
So there are several companies that are developing or have blood tests. The one I referred to, the first one, I believe the first one, was a company developed by two of my colleagues here at Washington University in our Knight Alzheimer's Disease Research Center. I mentioned Randall Bateman. He's one of the co-founders, and the other is David Holtzman, who is the chair of our neurology department. So Randy and Dave wanted to take the findings they were studying in their laboratories and make them widely available to the public at large. And we in academia are not set up for that transformation from lab discoveries to commercial enterprises. So they founded this company called C2N, C2N. And it is the C2N company that announced in, I think, November, that they have this available test for a blood test to detect amyloid in the brain. And they used a number of samples from our research volunteers here at the Knight Alzheimer's Disease Research Center, because all of our volunteers not only have blood tests, but they also have spinal fluid examinations, and they have amyloid PET scans. So the company was able to say if they found a certain level of amyloid in the blood or the plasma, whether it correlated with amyloid as depicted in the amyloid PET scan. So it was a good situation. I do not have any financial or other interest in the company C2N, but I think it's important to know that my colleagues do, and they work for Washington University, so Washington University does. So there are, I'm being careful, I don't want people to think that, I don't think I have a conflict, but clearly my colleagues and the university are going to stand to benefit financially from this discovery. Now, right now, the blood test has been marketed, and I think appropriately so, for people who have symptoms of dementia. So if people are demented and the physician is evaluating them and the consideration of Alzheimer's disease as the cause of dementia comes up, then I think that's the scenario that the blood test can provide support for that diagnosis of Alzheimer's disease dementia, because we know that it correlates very highly with the presence of amyloid plaques, as shown by the amyloid PET scan. Eventually, I think it could be used to identify people at risk for Alzheimer's disease. I mentioned that Alzheimer's, amyloid may be silently building up in the brain for decades before it causes enough brain damage that dementia occurs. And maybe it is important, it could be beneficial to identify people at risk of developing Alzheimer's disease dementia. But the caveat is, as of yet, we don't have anything to offer those people if they find out that they are at risk. We don't have any approved treatments for that as yet. Now, hopefully that's all going to change with this aducanumab or something else, but we don't have that as of yet. So right now, I think we in the clinical realm of Alzheimer's disease dementia are trying to find out the right use of the blood test. And I think we will. And I think, as I say, we'll get more experience with it and find where it's best utilized. And I truly hope that it will get, and I think it will, FDA approval and and then coverage by Medicare and other entities. So we're just trying to see where it fits. I am not recommending it, and I don't think the company recommends it for people who don't have dementia. So right now we're trying to find its right niche use in people with dementia.
Thanks, John. There's a couple of questions here. Two of our guests tonight. One had head trauma requiring a craniotomy and is concerned about the risk of dementia and would like to hear your thoughts on the relationship between head and traumatic brain injury and dementia. And the second person has Parkinson's disease and would like to know the relationship between Parkinson's disease and dementia. And as you mentioned previously, some Alzheimer's disease patients, many in fact, have other pathologies. So I guess the other question here is the proportion of patients with Parkinson's disease who could also develop Alzheimer's disease.
Yeah, both very good questions. The role of head trauma, brain injury due to trauma, and the risk for Alzheimer's disease has been one that has been studied for decades. And I think you can get arguments on both sides that head trauma does put one at greater risk for future Alzheimer's dementia, or if you look at another group of investigators, it doesn't increase one's risk. I don't think the answer is known, but I do want to mention this unique form of head trauma that is sustained by amateur but also professional athletes, certainly people who are NFL players or National Hockey League players, or even soccer players with all their heading of the soccer ball. There's no question that those individuals develop a brain disease that can be characterized by dementia symptoms. Often there are other symptoms, more personality and so forth. These individuals have something called chronic traumatic encephalopathy, CTE, and it is not the same as Alzheimer's. There is no amyloid in these people. So it's a dementia syndrome, and it has some similarities to Alzheimer's and certainly has the tau abnormalities, but it's not the same as Alzheimer's. So I think for the individual who had head trauma and had to have a surgical procedure, that I don't think, my opinion, that it is at all certain that that is putting that individual at greater risk for Alzheimer's disease dementia. Parkinson's disease is very interesting. There is great overlap between Alzheimer's disease and Parkinson's disease. In the advanced stages of Alzheimer's disease dementia, Many patients develop Parkinsonian features, stiffness, and slowing, and gait abnormalities. In the later stages of Parkinson's disease, many people develop dementia. And it turns out that not uncommonly, when you look at the brain of someone who died with Alzheimer's disease, they will have the characteristic feature of Parkinson's disease called the Lewy body in their brain. So Alzheimer and Parkinson pathology go together, matter of fact, about half of the time. So there is clear overlap between the two. And then in the middle, there are people who have Parkinson's disease, largely a motor problem, but in later stages could develop dementia. There are people who have Alzheimer's disease, major problem dementia, but later stages could develop the motor symptoms of Parkinson's. And there are some people in the middle, this is dementia with Lewy bodies, who have features of both. And these individuals are difficult to diagnose. I mentioned many practicing physicians, primary care physicians, simply don't have the time or interest to make a diagnosis of Alzheimer's disease, the most common form of dementia. They certainly are not going to be able to make a proper diagnosis of people with less common forms of dementia, such as dementia with Lewy bodies, but that is sort of an intermediary between Parkinson's disease and Alzheimer's disease. Dementia with Lewy bodies has features of both. It has dementia like Alzheimer's, and yet it has motor changes as well. So there is a relation between Parkinson's and Alzheimer's, not well understood, but to the American Brain Foundation's credit, they are, as was mentioned, stimulating research into the proper diagnosis of this intermediate form, dementia with Lewy bodies, so we can better study it and perhaps unlock how Parkinson's disease and Alzheimer's disease are interrelated.
Thank you, John. Well, clearly we could keep you here for another hour at least. But in our last few minutes, maybe I'll ask one final question, because there's a few questions that came in on genetic risk and gene testing. Have some comments on that?
Yes. So this will take me about an hour to answer, so no problem. So number one risk factor for getting Alzheimer's disease is getting older. That's number one. Age. Second is genes. And there are three ways gene abnormalities can cause Alzheimer's disease. One is Down syndrome. Now, people with Down syndrome don't have abnormal genes, but they have one too many copies of the gene that produces amyloid. So we're supposed to get one set of genes on chromosomes from our dad, one set of genes on chromosomes from our mom, and those chromosomes pair up. In Down syndrome, one parent, usually the mother, ends up giving two chromosomes to the dad's one. So these individuals have three copies of the chromosomes that carry the gene that encodes for amyloid beta, which means all their life, from the time they were conceived, people with Down syndrome overproduce amyloid. They have three copies producing, three genes producing the amyloid protein rather than two. So 50% greater amyloid. And everybody who has Down syndrome, if they live to age 40 or beyond, will have Alzheimer's disease in the brain. So it's a early onset form of Alzheimer's disease. The second genetic form is a very rare form of individuals who have a gene that causes Alzheimer's disease. We know of three genes. When they go bad, we call that a mutation or a pathogenic variant, but a normal gene isn't normal, it's abnormal in some way. There are three genes that we know about that if you have an abnormality in one of those three genes, you will develop Alzheimer's disease. It's very rare, about 1% less than 1% of everyone with Alzheimer's disease has this form of the disorder. But it is a very tragic disorder. It's like some of you may know the story about Huntington's disease. It's the same thing. If your parent has the gene, they will develop Alzheimer's disease dementia, usually at a young age. Age 45 is average. Some people older, some people younger. Some people with the bad gene develop Alzheimer's disease dementia in their 20s. If your parent has that gene, he or she will have Alzheimer's dementia at a young age. And each of their offspring has a 50-50 chance of inheriting that bad gene. If they don't inherit it, they are at no more risk from Alzheimer's than anybody else. If they do inherit it, just like their affected parent, they will develop Alzheimer's dementia and at an early age. So we call this autosomal dominant Alzheimer's disease, because if you get the gene, you're going to get the disease. I mentioned that first prevention trial. It was done in families who carried a bad gene, and it was individuals who had not yet developed dementia, but were at high likelihood of developing it because they had the mutation. So that was the first group of people to get a drug in trying to prevent Alzheimer's disease. Well, I know we're over time, I apologize, but the most common type of genetic influence in Alzheimer's disease is not an extra copy of the amyloid gene or a bad gene that causes Alzheimer's, but we all inherit from our parents sets of genes that give us certain characteristics. I don't know if you can tell from the Zoom that my parents both were of Northern European heritage, and I happen to be, I used to be redheaded, then I had kids, and now I'm gray-haired, but I'm very lightly pigmented, very pale skin. That's a genetic influence. My siblings are the same, which means I'm very prone to getting sunburn if I don't put on sunscreen. Now, my genetic inheritance, pale skin, makes me at risk for getting sunburn, but will not cause me to get sunburn. I have to go out in the sun. So I'm susceptible, but something has to trigger me getting sunburn, exposure to the sun. Well, that's what we think the vast majority of genetic influences in families are, not genes causing the disease, but putting one at greater risk. And we were looking for what those risks might be, what the triggers might be, like sun exposure for sunburn. We're trying to figure that out. But you can also inherit a gene profile from your parents that protects you against Alzheimer's. So that the most common reason people have genetic risk for Alzheimer's is not a gene that causes the illness, but puts us at greater risk for the illness. And those genes can travel in families, and that's why we often see family histories. I know I went on too long. I apologize.
Not at all, John, not at all. That was a tour de force. In all the sessions, all the donor salons I've moderated, we haven't had close to this number of people attending. Nobody's left. And again, we could go on for another hour with the questions, but I can't thank you enough for being here tonight. The way you explain things is so crystal clear. Thanks, everyone. Have a great night.
Bye-bye, everyone.
Bye-bye.